So let's kick off now with my good friend, Prof. Osman. Can you please explain, Prof, what the ESC guidelines, the current European Society of Cardiology guidelines, state about this important topic?
Thank you very much indeed, Yasser. It's a pleasure to be here with you talking about the ESC guidelines for atrial fibrillation. So I'm a cardiologist and electrophysiologist here at UHCW in Coventry, and also working with Warwick University. So the European Society of Cardiology guidelines for atrial fibrillation are a very, very comprehensive and useful set of guidelines. The ESC have really provided guidelines over the last 15, 20 years and have regularly updated them. And the last update was in 2020. And one of the things that's actually very helpful about the ESC guidelines is that they are updated very, very regularly. So it would be interesting, I guess, to find out how many people are aware of these guidelines.
Yeah, let's have a poll on that. So if we can have some interaction from the audience, how many of the audience are actually familiar with the latest European Society of Cardiology guidelines on AF? And if you look below your video player, you should have the option to give your answer, and we'll give you a few minutes, not a few minutes, a few seconds to input your answer, and it'll be quite interesting to see what the results are. Faizel, while we're getting these results, can you explain to the audience how you perceive the European Society of Cardiology guidelines? I mean, a lot of cardiologists I speak to tend to use them as a sort of reference guide. In your opinion, is that correct use of them?
Yeah, that's a very good question. I agree. I think they are a very good reference guide. There are other guidelines, of course. Here in the UK, we have the NICE guidance as well that's been updated recently. I think the beauty of the European Society of Cardiology guidelines is that they are updated frequently. They incorporate all the latest data, and it's a pan-European, very often American specialty that that actually makes up the core of the people that write these guidelines. So for me, I would say they are the gold standard.
Fantastic. So let's see what the audience have inputted in terms of their familiarity with these guidelines. Can we get the poll responses up on the screen? Nope. Have we got the results? Have we got the results? Yes. So I can't see those. Is that 100%? Yeah, so 100%. It seems like 100% of the audience, Faizel, that's quite reassuring, are actually familiar with these guidelines.
Yeah, no, that is very, very reassuring. Absolutely,
Fantastic.
absolutely. And Pat. And so now that will hopefully make life easier. So I'm just going to run through some of the background around atrial fibrillation. So the audience out there, and will be very familiar with some of this data. We know that AF is the commonest arrhythmia worldwide, and certainly in the Western world. We also know that the prevalence and the incidence of atrial fibrillation is rising. So over the coming several decades, we are going to see more and more atrial fibrillation. As you quite rightly pointed out, AF does increase the older we become. It is more common in males, but females also have a slightly higher risk of stroke from atrial fibrillation. And something that's quite startling is that if you're in your 50s and you're in a room full of people, there are 3 of you in total, there is a 1 in 3 chance one of you will get atrial fibrillation. And that's quite startling when you put it in those terms. So it really is an arrhythmia that affects the whole community, and we are going to see more and more of this arrhythmia. In terms of the classification of atrial fibrillation, this really has remained fairly unchanged over the last several years, and we have the classification of paroxysmal, where AF comes and goes by itself, usually lasting no more than 7 days, typically terminating within 48 hours. Persistent is where atrial fibrillation lasts beyond 7 days. Long-standing persistent atrial fibrillation is where AF lasts for more than a year continuously, and permanent is where it's accepted that the patient has atrial fibrillation, and both the persistent atrial fibrillation, and both the patient and the physician have accepted it, and it's there all the time. time. There is this entity of first diagnosed atrial fibrillation, and patients can, of course, have a first presentation with either paroxysmal, persistent, or permanent. There are certainly certain terminologies that are now not used as much, and the guidelines suggest that we should perhaps avoid them. And they are terms such as lone AF, valvular, non-valvular AF, and chronic AF, because they do generate some confusion. So why is AF important? And again, you very nicely highlighted, Yasser, some of these. We know that patients can present with symptoms, and that impacts significantly the quality of life. Typically palpitation, breathlessness, fatigue, but other symptoms can also occur that can result in hospitalizations. Importantly, a significant number of patients can be completely asymptomatic, so they can be at risk of all the problems of AF and not even realize they've got it. And that case that you highlighted of the lady who had a devastating stroke, again, if somebody has AF not realizing it, that can be potentially life-changing. We know that AF is associated with some very negative outcomes. There is an increased risk of mortality. We know also that there's a higher risk of stroke in these patients. We know that there's a risk of LV, left ventricular systolic dysfunction, and heart failure, increasing recognition of dementia and cognitive decline. There's also depression because of the symptoms and the quality of life that is impacted. Patients having recurrent admissions to hospital and hospitalization, and that's a huge part of it as well. And of course, that is a huge burden on the finances of healthcare providers as well. So all of those things are very, very important. Yes, sir.
Okay, so that's really helpful. You mentioned, Faisal, I can't help asking this question, that there's certain terminology we shouldn't use. In primary care, I often see this terminology of AF resolved, or this read code of AF resolved. Can you truly resolve AF, particularly when it comes to stroke risk?
So that's a very good question. I think atrial fibrillation, it's a spectrum of a condition. So very often starts as paroxysmal and then can transition into persistent. And clearly there are things we can do to delay that or slow it down, or to try and prevent it from recurring back. However, as you'll see in the coming few slides, atrial fibrillation, sadly, is a condition that becomes more common the older we become. And as the heart becomes older, develops more fibrosis, becomes a little bit more dilated, atrial fibrillation is likely to come back. And there are several things you can do. There are medications we'll talk about. However, the risk of atrial fibrillation is always there that it may come back. So I always hesitate to use the word cure atrial fibrillation. I prefer the word treatment rather than cure.
Fantastic. And you mentioned that the ESC guidelines update very regularly, far more regularly than perhaps our national guidelines. What's new in the latest iteration of the ESC guidelines in relation to AF management?
So you're right. The European Society of Cardiology do update the guidelines much more frequently, and I think that's a very helpful thing to do, because it takes into account up-to-date trial evidence, and actually that can be incorporated into practice. So in the 2020 guidelines, there are a few things that are new and that have been updated. I've tried to highlight here in red. So the ESC recognized that atrial fibrillation now can often be diagnosed by patients themselves, because nowadays people have smartphones, smartwatches, smart devices, even blood pressure monitoring devices that can record heart rhythm. And they often have a single channel recording. So in the past, we'd certainly say that atrial fibrillation, you'd need a 12-lead ECG, but recognize now that actually you can diagnose atrial fibrillation from a single rhythm strip, and the guidelines talk about having 30 seconds or more of an irregular rhythm with no regular atrial activity or P wave that is seen, and that can be diagnostic of atrial fibrillation, and that's very, very important. So this slide just shows what sinus rhythm would look like. You have clear atrial activation, a clear P wave before each QRS complex, and the QRS interval, the RR interval, is regular. However, in atrial fibrillation, there are no discernible P waves, and the QRS activation, the RR intervals, are completely irregular, and that is diagnostic of atrial fibrillation. So what else is new in the guidelines? So I think very helpfully, the guidelines now also talk about risk factors for atrial fibrillation. And these slides highlight some of the risk factors that can be associated with atrial fibrillation. We know that there are some things that we can't do anything about: aging, genetics, male gender, and ethnicity. However, there are a lot of things that we can do something about. So patients who have comorbidities such as hypertension or diabetes, people who are overweight or obese, we know that impacting, controlling those things and improving those things can have an impact on the atrial fibrillation. Other things such as obstructive sleep apnea, and there's a lot of recognition now that obstructive sleep apnea is associated with atrial fibrillation and can be. Alcohol and smoking, again, lifestyle choices. It's important that everyone is aware that these things also impact your outcome in atrial fibrillation, and hyperlipidemia. So again, a recognition there are a whole host of things that we can do something about to reduce the risk of atrial fibrillation. Now, the guidelines also talk about identifying lifestyle changes and tackling weight issues. We also know that, particularly when it comes to atrial fibrillation ablation and treatments, the risk of recurrence is higher if these risk factors aren't tackled. And the guidelines now talk about tackling those risk factors, particularly when it comes to therapies such as AF ablation. And there's also a recognition that actually opportunistic screening can also be very, very helpful and very useful when we're talking about atrial fibrillation and ensuring that we try and identify those particularly at risk with opportunistic screening, particularly those that have hypertension. So we know, as I've touched on previously, that there are a number of screening tools that are available. We're all now wearing a lot of devices. I have an iWatch now, not that I'm advertising for Apple, but we all have devices that we're wearing. We have smart watches, smartphones, and we are going to be picking up more and more atrial fibrillation. And again, the guidelines recognize that actually there is going to be a higher awareness by patients. And they talk about opportunistic screening in people who are 65 or more, and perhaps having a more systematic approach in those that are 75 or more, where we know the risk and the complications associated with AF are higher. We know, obviously, from the guidelines that to make a definite diagnosis of AF, you need a 12-lead ECG, but the guidelines recognize that with these new devices, that often it'll just be a single-channel ECG recording. And again, they very usefully have said that actually 30 seconds or more of something that looks like atrial fibrillation is then enough to diagnose atrial fibrillation. And so with that, I'll hand back to you, Yasser.